And now we have questions, 5 minutes from the panel, and I'm going to start with myself. And, let me just say I'm not looking for a response, but I really appreciate, Ms. Roberts and Holmes, that you came today, and I'm not being critical in any way because I know you took your time, but I really have to stress that, this draft is not meant in any way to put together a single payer system or emulate Canada. I mean, Canada's a nice place, but I'm not really looking to create a Canadian system or even praise the Canadian system, because I really believe that the draft implements a uniquely American system that in no way replicates Canada. But, I appreciate your being here, and I'm not trying to,
the problem is what
denigrate it in any way.
It's a very slippery slope once you start on that sort of road.
Right.
And unfortunately, a lot of the Americans that I'm talking to have said to me, oh, well, we're going to get free health care too. We're going to get Canadian style health care.
Well, I think you're right that there's some people who think that somehow, this is single payer, but I just want to stress that I don't think it is, and I don't see how it becomes a single payer. But whatever, I appreciate your being here, and I don't want to take away in any way the fact that you came here and how difficult I'm sure it was to be here. Let me ask a question of Ms. Wright Edelman about Medicaid. I'm very proud of the fact that in this discussion draft we've really addressed Medicaid in a major way, in the sense that we're trying to cover and fill in the gaps, with 100% federal dollars for those who are not covered by the states now, up to the 130%. That we're increasing the reimbursement rate so that it's more like Medicare. I mean, a big part of this is Medicaid, and I think in many ways it hasn't really gotten attention, unfortunately. But what I wanted to ask you is, there have been those who say that if we set up what's in the discussion draft, that Medicaid would no longer be needed, and that those people who are in Medicaid should be put into the exchange, be able to get their insurance through the exchange. The draft doesn't do that, and because we're concerned that that might be harmful, at least initially, to Medicaid. So I just wanted you to discuss the types of benefit and cost-sharing protections available in Medicaid that are generally not found in private health insurance products. And if you can talk about the need to keep and improve Medicaid's safety net undisturbed for years to come in response to those critics. We're not putting Medicaid in the health exchange.
You will not.
And I'd like you to comment on that.
Well, do not put Medicaid into the exchange. Nobody should end up worse off than they are currently. Medicaid is a crucial safety net. I applaud in my written testimony your extension of 133% for all, and the adults that need that help, I applaud you for it. I'm glad that you're reaffirming it for children, but all children are currently covered at that level, so it will not result in an increase. But what we do hope you will do in protecting Medicaid, in fact, I'd like you, if you want to take it up to 300%, that would be wonderful too. I don't care how you do it, as long as you can kind of try to get all those folk who are uncovered, but I think that Medicaid is essential. Its comprehensive benefits, as I go for children, is essential. The fact that it's an entitlement is absolutely crucial, and I think it's one of the strongest pieces of what you have done. On the children's front, I hope that you will make sure that Medicaid's benefit protections are extended to CHIP children and children in the exchange, because we think it is the most appropriate benefit package, and so we hope you will do that. But it also raises another important point, because many of the children now at 133% of poverty under Medicaid are eligible but are not getting it because the bureaucratic systems are impeding that. And so one of the things that's essential, if the children under 133% of federal poverty level are going to get their Medicaid coverage, we're going to have to simplify. And we've laid out a number of simplification steps. One of the good things you have in your provisions is automatic enrollment of any child that is uninsured at birth. I think that's fantastic. We'd like to see automatic enrollment for any child that's in any means-tested program. We would like to have 12 months continuous eligibility. We've laid out a number of steps that can be taken to ensure that those children currently eligible for Medicaid will in fact get it. But you're going to have to do the systems reform to make it effective.
I appreciate it, and I'm sorry to stop you, but I want to ask another question of Ms. Hanson. Yesterday the pharma and the president announced some kind of a deal to cut costs for seniors with incomes up to $85,000 in the donut hole by 50% In other words, to fill in the donut hole in part, people whose incomes are up to 85,000, that they would only pay 50% for brand name drugs once they fall in the donut hole. Now, I'm not taking away from that. I appreciate the fact that the pharmaceuticals are doing that. But in the discussion draft, we fill about $500 of this cost for the donut hole immediately, and then phase out the donut hole for all Medicare beneficiaries over time. And we also reinstate the ability of the federal government to get the best price for prescription drugs for the most vulnerable low-income Medicare beneficiaries. Those are the rebates, again, to fill the donut hole. How do you see this provision in the draft, the discussion draft, as working together with the commitment by the pharmaceutical manufacturers yesterday? I mean, I don't see them as mutually exclusive. I think they're both positive, but I just want you to comment on that.
Well, I have actually not.
Well, I was going to ask Ms. Hanson initially.
Good.
Go ahead. I'm sorry.
That's all right.
We're just out of time, although always
Good.
here. Go ahead.
Thank you. Well, Mr. Chairman, we agree with you. This does not preclude the continuance of it because it is actually only 50% of the donut hole. And for people who are at that income level, it doesn't cover every Medicare beneficiary. But it's part of what it does do for the people who are on drug coverage, as I stated briefly, that people who are falling in that hole are not oftentimes continuing with their medications. So part of our job as an organization is to really get the most relief in the quickest time on behalf of people who are already in that conundrum. I mean, that even relates to people who are becoming bankrupt as well. So that cost element is really important. I think what the draft does is importantly to continue to build on that so that we have a more whole, seamless coverage on behalf of people. So I do think that they can work, and we're continuing to work with you on making sure that that coverage continues.
And I appreciate that. I know you were part of this deal, I don't know if that's the right word, or agreement yesterday, but I also appreciate your working, with us to try to completely fill the donut hole.
Right. Well, I just wanted to be really clear that I think it was Senator Baucus who really took the leadership role with pharma, and I know that the president supported it, and we, again, appreciated it because it makes such a big, real difference in people's pocketbooks.
We try not to talk about the Senate here, but there are occasions when we have to acknowledge their existence. The gentleman from Georgia, Mr. Gingrey.
Mr. Chairman, thank you. I want to ask Ms. Shona Holmes, first of all, thank you for your testimony. We really appreciate that. And I, as a medical doctor, I mean, I understand, I think, what you were describing to us, I guess a benign pituitary tumor. The pituitary gland is about the size of your little thumbnail in the normal circumstance. But when it's growing so rapidly, as in your case, it's right in front of the optic nerve where it crosses over, and as it compresses on that optic nerve, as it gets larger, that's what would lead to the blindness. And I'm assuming that the doctors at the Mayo Clinic in Arizona informed you that and said that, hey, you really need to get this surgery done within about 6 weeks. Now, you went back to Canada, and I understand from your testimony they said that there was no way they could do it in the 6 weeks. Did they say why? Did they have a reason for that?
Well, the biggest problem in Canada is that the wait times, even just to get into specialists in order to get diagnostic testing done. So when I returned to, in fact, I had this false sense of security when I was in Arizona because 2 of my doctors were in fact Canadian. I've never questioned the talent that comes out of the medical system in Canada. They just don't have the resources. And so when I saw these doctors, they said, go home. You can get this done at home, and you have insurance. This is what you should do. Here's your...
And you said it would probably have cost you $100,000 to have it done in the United States.
In total, with all my expenses and everything being away. And I had to return. I took 3 solid runs at this particular situation. So this is not just that I fell through a crack. And I had to go back. I had to go originally for diagnostic testing. I had to go back for surgery, and I had to return for follow-up because I couldn't get any of those things done in Canada.
So there was a real problem with rationing, basically a long queue and getting.
And at the time, I was also diagnosed with a potential tumor in my adrenal. And it was recommended at the Mayo Clinic at that time that I have that surgery, and, you know.
That additional surgery, and also that was going to be delayed in Canada as well.
3 years
Yeah.
to the date, I had.
Let me. I've got time's running out, but I want to ask you one other thing. In your testimony, you credit the United States healthcare system for saving your life. You just said that. You also mentioned your lack of rights as a patient in Canada. Tell me, as someone who has seen health care from both sides of the Canadian border, what advice can you give to American patients who may be following this debate in Congress? Now, keeping in mind what our chairman, and I know in all sincerity, he mentioned that this is, in his opinion, not, nor is it designed to lead to a single-payer UK or Canadian-type system. That's what Chairman Pallone said. You have some concerns about that. I have some concerns about that with this public option. What would you say to the American people in regard to this?
Well, it's my understanding from, actually all my family is in Great Britain, and it actually is a two-tiered system. They actually have public and private, and they're almost in worse condition than we are. What I'm saying is I am insured. I have insurance, but the money isn't there. It's expensive. Healthcare is expensive anywhere. And I was promised that I had insurance, but when it came to using the services that I was supposed to be covered for, they weren't there.
Yeah, so having an insurance, a plastic card, doesn't guarantee you access, affordability, availability if there are no physicians there to provide that care. Great point. Thank you very much for your testimony and for your response. I want to go now to Dr. Novak. Dr. Novak, thank you. I know you practiced orthopedic surgery is it in Arizona? I think you mentioned to us. And you referenced in your testimony the study published, I think, May of 2009, the Journal of Health Affairs. 1 in 5 Massachusetts adults were told in this last year that a desired physician was not taking new patients. Here again, they had insurance, they had coverage, they just couldn't find a doctor. Do you know if the type of insurance a person carried influenced their ability to see their desired physician, whether it was the public plan option or a private plan option? Was there a delta in regard to who could get?
I don't have an answer for you on that, but what it's illustrative of is the regular attempts to conflate health insurance with health care. So when we hear the 47 million number, which is a bit inaccurate in and of itself, that don't have health care, those are people who don't have health insurance. And since 20 million of those people change every year because of job changes, et cetera, about 10 million are in the country illegally. About 10 million are between 18 and 30 and don't think they'll ever get sick. Yeah. You're left with about, as I mentioned, about 3% of the country that's chronically uninsured. So just giving people health insurance, what we see in the Massachusetts example, is no guarantee that you have access to health care.
Well, Mr. Chairman, if I might ask Dr. Novak to submit a written answer to my question in regard to the different discrepancies between or among the plans where there were no doctor available. I would appreciate that. My time's expired, and I yield back.
Yes, it is a pleasure now to yield 5 minutes and to our chairman of the full committee, former chairman John Dingell.
Thank you, Madam Chairman. I'd like to begin by welcoming our old friend and my very dear personal friend, Marian Wright Edelman, to the committee. Delighted to see you here, Marian.
Nice to see you.
I want to get right down to the business at hand here and to say to you, Ms. Holmes, welcome. Your comments I found to be most interesting. Tell me, you are referring to the single-payer system you have in Canada, is that right?
I certainly am, yes.
You're aware that the bill that's before, rather the draft that's before us is not a single-payer bill?
All I'm aware of is that I needed to tell what.
So, so then help me, how would your concerns with a single payer system apply to the draft of the legislation we're working on today?
My concerns are basically in order to open up the communication so that people know the questions to ask when a bill is passed, so that they know what is safe to get into it.
In other words, your comment is a warning rather than a criticism.
Just my experience.
Well, I think it's a very good criticism, and I thank you for it. Or rather, a very good warning as opposed to criticism. Now, Dr. Novak, I found you made a very frightening comment here that I'd like to address with you, because if your fears are correct, this is a very bad situation. And in this, and I can tell you that I'm going to stay up night and day to get it out if there's anything like that in here. You made this statement. You said, no matter what name the bureaucrats and politicians want to use, the plan being put forth by the committee will mean Washington bureaucrats will have the power to deny you care. That's a very frightening statement. And I'd appreciate it if you can tell me where in this draft that there is language that would authorize that, so that I can get this out. I'll work with you to get it out. Now tell me where it is.
Well, I think the issue here is when we look about, when what's been very vague, of course, is exactly how the cost control is going to happen.
No. Where's the language? You made a bald, flat statement, and frankly, I'm scared to death. Now I want you to tell me where it is in there so that I can get it out.
Well, I don't have the exact line for you, sir, but I can get that to you ready.
But where is it, Doctor? Now, I'd probably being unfair to you because you're a doctor and I'm a lawyer. And I would never presume to tell somebody how to take out an appendix or to fix or to replace a knee. But I do know a little bit about drafting laws. Been doing it for about 50 years. And you made a statement that scares the bejeebers out of me, and I want you to tell me where it is.
Well, I don't have the exact line numbers for you, but I will get it for you.
So you've made the bold statement, though, which you are not able at this time to tell us where the language is in the bill that has caused you to make this statement. And I'll repeat it again because, quite frankly, it's a very serious charge. No matter what name the bureaucrats and politicians want to use, the plan being put forth by the committee will mean Washington bureaucrats will have the power to deny you care. And you capitalize deny you care. Where is
again, the answer here is that we know that care is going to be denied because you have to come up with a package. The plan is to come up with a standard benefit package and then to give some authority the ability to determine which benefits are going to be accessible to, it'll start with seniors, I imagine, if we start to applying this to patients in Medicare first. And if those benefits are different than the benefits that people currently enjoy today, that will potentially be care that will be either delayed or denied for what they're getting right now.
And then that's the basis for your statement, is it?
Yes.
I find that to be interesting. It's kind of like building a house of cards here, or maybe setting up a straw man. And that's a good thing to do because then you can knock them down fairly easy. But I still want to hear you tell me what is the precise thing. We're going to, let's go to something. You got Blue Cross Blue Shield. You got Aetna. You got all kinds of insurance companies in this country. You remember when we had the big fight over Patients' Bill of Rights? Remember that?
Not entirely.
AMA was very, very interested in it, and they were very, very helpful to me in my efforts to try and get that legislation through. That was to stop a bunch of health insurance bureaucrats and green eye shade actuaries from telling you as a doctor what you could do and telling me as a patient what treatment I could get. And I find that your same apprehensions were joined in by my friends at AMA when we tried to correct this iniquitous situation which we have now. And I'm trying to find out where the abuses that we complained about are to be found in the legislation.
Well, sir, I
And,
think
and
what
how,
this,
how this situation, even if it is, as you say, is true, would be worse than that which we have now, where we have 47 million Americans who haven't got any health care and who haven't got anybody to tell them what they can have or not have. The only thing they can say is, you can't have treatment because you can't pay your bill.
well, I think the question is, what kind of trade-off are we looking to make? It is true, and I can tell you both as a provider and as a patient advocate, that there's oftentimes no love lost between me and the bulk of the private health insurance industry. But the trade-off that the legislation appears to be making is to be moving away from green eye-shade private health insurers towards green eye-shade Washington bureaucrats. And I think at the end of the day, when we look at examples where there have been abuses in the private health insurance industry, there is recourse. When Blue Cross did rescissions in California and the other companies did rescissions in California, there has been significant answers to that.
I'd love
my
to
concern
listen.
is, for example, in the VA
Doctor,
system,
I'd
which
love
is
to
government
listen
run,
to you.
there is no
I'd love
recourse
to
for the
listen to you
10,000 people who
further,
are exposed to
but my
HIV
time
and hepatitis.
has expired. Thank you.
Thank you, Mr. Dingle. And I yield now 5 minutes for questions to Mr. Whitfield.
Thank you, Madam Chairman. Let me ask you, have any of you read this bill? Ms. Edelman, have you read the legislation?
I have read, or my staff has read it multiple times, and we have struggled to make sure that I read the key portions of this bill that relate to children.
When did you all receive it?
We got it on Friday, and it's over 800
Okay.
pages long, and but we've done the best we could.
Well, I don't think any of you have read it. Certainly, I have not read it. Not many members up here have read it.
Well, we read it.
And one of the things we're concerned about, when you have this sort of dramatic change in health care, and evidently this bill, they're going to try to bring it to full committee the first week of July or the second week of July, we don't really have a lot of time here. And but let me just talk philosophically about a couple of things, and then I'll get into some specific questions. I would ask all of you, does the American taxpayer have the responsibility to pay for non-emergency health care for illegal immigrants? Ms. Edelman, what do you think?
I think all children should be covered because it's a public health issue if there are any children in our country or in our schools.
What about adults?
All children go to school.
What about adults?
Well, I'm here to talk about.
Okay, you're talking about children.
Our
Okay.
bill is
What about you,
all
Ms.
children
Hanson?
being covered.
What about you,
I think
Ms.
it's cost
Hanson?
effective and preventive because they're going to show up.
What
in
about you,
emergency
Ms.
rooms.
Hanson?
We don't have a policy on immigration because that's not part of our public policy covering our.
So you don't have a position? Okay, Dr. Sheen, what about Sharon?
Similarly, we don't have
Okay.
a position on.
Okay, Dr. Novak?
I would just say currently as a provider, and I take about 14 days of emergency room call every month, I take care of, in the Phoenix area, a whole lot of people who are not in the country legally,
Yeah.
and they get the same care.
But I said non-emergency room care. Okay.
I think that given the tens of trillions of dollars
Okay.
of unfunded liabilities, that we
Okay.
ought to be directing the
Okay.
resources for people in the country legally first.
Well, there's been a lot of discussion here about there's not going to be any government payer plan or government plan, and yet in Section 203 of the bill, which very few of us have read, it says the commissioner that will be established under this legislation shall specify the benefits to be made available under exchange participating health benefit plans during each plan year. And I've been told that that applies not only under the government option, but also private plans. So do you think it's right that some government officer will be dictating what benefits will be available under private as well as the public option plan? Dr. Shern?
Well, I think that the intention, as I understand it, of that provision is to provide a floor of services that will be available for everyone upon which you can build. And I also think that if we look at the way
That's your understanding. Do you know that to be a fact?
No, I don't know that to be a
Okay.
fact.
What about you, Ms. Hanson?
I can't answer it with.
Have you read the bill?
Not since Friday.
Okay.
But the staff.
But you all have helped work on this legislation. You've been a part of drafting this legislation. Is that correct, Ms. Hanson?
We don't draft for legislation. I think we are.
Did you have input into it?
There have been conversations between our staff.
Okay. Now, the CBO says that they estimate 15 million people will lose their present health insurance coverage as a result of this legislation. So, Ms. Hanson, what would you say to your members who will lose their employer health coverage because of this bill?
Well, we take the position that the principle of choice, and we also support that people who have insurance now can and want to keep that. And that's something that we actually believe in the maintenance of a public and a
Does this legislation give each individual the right to keep their current insurance?
Those are the principles that we are supporting.
But do you know for a fact that it does it? Do you know for a fact that it does it?
I don't know for a fact personally,
Okay.
but the principles I can ascribe to. And that.
Now, my understanding that this legislation also includes an employer mandate, which will force businesses to either provide health insurance to their employees, which is fine, or pay a tax of 8% of wages paid. Now, that's going to particularly hit hard small businesses. And there have been estimates that there may be 4.7 million Americans that would lose their jobs because of the additional tax that small businessmen and women will have to pay. Does that concern you all? Does that concern you at all, Dr. Shern?
If those estimates are correct, that would be a concern.
Yeah. Ms. Hanson?
Right, we feel that the ability to cover should also be supplemented by understanding affordability and cost for both employer as well as the employee.
Okay.
But it's also my understanding that small businesses can buy into a public plan, but everybody should be contributing something.
Everyone?
There should be a shared sacrifice.
Let me ask you a question.
Americans.
What would you think if we just took the money that this plan is going to cost and just put everyone under Medicaid? I mean, I know you're a supporter of Medicaid. It is a good system. What do you think about that?
Well, I think that the committee can deliberate. I don't care how we do it. We should thoughtfully determine that we're going to get health coverage for everybody.
But would you
what
be
they're
opposed?
trying to do here
Would you be
is to give
opposed to?
people
Would you be
choice.
opposed to everyone being under Medicaid?
I would not be opposed to all children being in Medicaid. That's what I know
What
about.
about
and
adults?
with the Medicaid benefits, but I think that the issue here is how we're going to give everybody coverage and choice about a public or a private.
And my
plan,
question
I
is, would
support
you
that
object
way.
to everyone being under Medicaid?
I'm here to talk about children today and to say whatever plan we do, that we should absolutely make sure that all children and pregnant women are covered, and I would love it if Medicaid took them all up to 300%, or all of the children got the Medicaid benefits and the Medicaid entitlement.
I think my time is.
Thank you, Mr. Whitfield. And may I just make a correction to a statement that was made? It's my impression or my understanding that CBO has not taken a position on this bill, and that actually a private public benefit advisory committee determines what the benefit is that should be on the floor, or what is offered in coverage in the new marketplace or sold in the new marketplace. And that's just for the record. And I now call upon, recognize our colleague from Colorado, Ms. DeGette, for 5 minutes.
Thank you, Madam Chair. And I want to add my thanks to Ms. Robertson-Holmes for coming today. It's always important to hear the patient perspective. And when you were testifying about the great care you got at the Mayo Clinic, I was thinking about my next-door neighbor when I was a little girl, Randy West. I knew him since I was 6 years old. And about 2 years ago, Randy was diagnosed with prostate cancer. And he was treated, and the doctor said they thought he was cured. And then the next spring, when his private insurance plan came up for renewal, his insurance company said they would renew his insurance, but that they would not insure him for any future complications he might have gotten from the prostate cancer. So he said, well, why should I get insurance then? Because that's the thing that's the most likely to affect me. So he didn't get the insurance renewal, and you know the rest of the story. Last summer, His symptoms returned. He went back to his old doctors. His old doctors would not now treat him because he didn't have health insurance anymore. And he spent about 2 or 3 months trying to get off of, trying to get on to Medicaid so that he could afford to go see the doctor and get treatment for his now advanced prostate cancer. And last week, on Wednesday, was Randy's 57th birthday. And he died suddenly of a heart attack because of the advanced prostate cancer that had riddled his body. So, you know, there's problems with the single payer system in Canada, but there's real problems for 47 million Americans like my friend Randy West, who died because he didn't get the insurance. And I don't even need a response to that. I just want to say what we're trying to do is make it so insurance companies don't deny people for those pre-existing conditions, and that so that people who have diseases in this country can go to the doctor. I just want to point out to you, Ms. Hanson, I want to thank you for mentioning the Empowered at Home Act in your written testimony, because Chairman Pallone and I worked on this bill a lot together, and what that does is it incentivizes states to provide home and community-based services, which allows disabled individuals to stay in their homes. It's not only a better health outcome, it's also more cost-effective. And so I want to thank you for that, and I think, Madam Chair, that's an important component to keep in the bill as we move along. And finally, I have to thank my dear friend, Ms. Edelman, all of our dear friend, and a real icon for children in this country, for coming over today. And I want to ask you a couple of questions about kids. As you know, I've worked for many years on kids' health. The first one is, do you think that as we design a program to try to enroll all kids in this country in health insurance or some kind of health coverage, that we should look at their unique needs and not just assume that the adult programs will cover them?
Yes, which is why we feel so strongly about the Medicaid benefit package, which has been thought through as being the most child appropriate.
Because it's targeted at kids.
It's targeted at children, and it's targeted at early diagnosis and early treatment. And so I don't think we need to reinvent anything, and I hope you will not come up with a benefit package, whatever it is, that takes away what children now have that works, and we want you to extend that package to all children, because that's what we think they need.
And that includes mental health.
Mental health, dental health is the comprehensive, all medically necessary services, and we think that should be Medicaid children, CHIP children, and any children, regardless of whether they're in the exchange or not.
Yes. We talked earlier, I think you mentioned in your testimony, the early and periodic screening, diagnosis, and treatment benefit. That's very expensive, though, and I'm wondering if you can opine as to whether you think that additional cost is worthwhile and might even save money in the long run for kids, and if so, why?
I think it would save money, and when we had Lewin and Associates do cost estimates for extending coverage to all children and giving them the Medicaid benefit package, they said that you could extend the EPSDT benefit package to all uninsured, 9 million uninsured children. This was a 2-year ago study, for about 12% added cost. And so I think that the cost effectiveness of this in the long run is going to pay itself back. And so we think it's not a big, huge add-on.
You know, part of the draft legislation, and part which I'm sure you have read because it applies to children, is the part that if children come in at birth and their parents don't have insurance, would automatically enroll them in Medicaid for the first year. Do you think that's a good step in the legislation? I think
that's terrific, and we'd like to have automatic enrollment when they go to preschool, or if they are in any WIC program or early Head Start program. You want to get children in because they are prevention. You want to prevent them. So
and preventative care for children actually saves
many dollars on the other end, and we can give you what added testimony to show you the cost of.
I'd appreciate it if you'd supplement your testimony in that direction. Thank you very much, Madam Chair.
Thank you, Mr. Gedden. Now, pleased to recognize for 5 minutes Dr. Burgess from Texas.
Thank you, Madam Chair. Ms. Wright Edelman, let me just ask you a question. On last fall, in the interest of full disclosure, I was a surrogate for the opposite side. I got to know President Obama's proposals last fall pretty well because I always had to prepare to argue against them. And one of the overarching themes that was always put out there first was that there was going to be a mandate to cover children under President Obama. Have you talked to him lately about what happened to that?
No, but he certainly knows that I'm expecting him to keep his promise. And I know that he has expressed his great interest in seeing that we take care of all of our children, and I think that this is the time to do it, and then the individual mandate here.
Let me interrupt, but I always had difficulty getting his surrogates to identify the definition of a child. Sometimes it was age 19, sometimes it was age 25, sometimes it was age 27. Do you have an opinion as to where that limit should be set?
Well, I certainly, we would take the definition of a child that's under Medicaid or CHIP now, but I think that we are talking about everybody getting coverage, and we know that there are a lot of younger people in college and young adults.
But in the interest of time, I've got to interrupt you. What is the difficulty with a child on Medicaid today? What is the difficulty with getting them in to see a dentist if they have dental coverage under Medicaid?
Well, the first part is Texas, since you have the highest number of unenrolled children, and we.
Yeah, but let's just focus on those that are enrolled. Those that are in Medicaid.
Well, bad provider reimbursement rates, we all heard, and because children do still face bureaucracies. But let's just take the child out in Prince George's County, Devontae Driver, who died last year. Tried to get 25, 26 dentists his mother went to, couldn't get them to take them because of low Medicaid and reimbursement rates, and I know you're trying to do something about that in your proposal. And the upshot was his tooth abscessed, then infected his brain, then he died, 250,000 emergency rooms. So huge bureaucratic barriers first, even to enroll children, and not enough providers, and in rural areas it's worse.
But fundamentally the problem has been reimbursement rates. Now, Dr. Novak, you talk about 14 days out of every month you cover the emergency room. And we have put a mandate on providers. We may not have a mandate for kids, we may not have a mandate on employers or a mandate on individuals, but you have a mandate called EMTALA, which requires that within 30 minutes of somebody showing up at the door, you have to see them. So is that not correct?
That's correct. And the consequence, of course, is that the very large majority of my colleagues just no longer have any privileges at the hospital. So for sometimes some complex things where it might be nice to have a particular person available, and when someone comes in through the emergency room, you're no longer even able to get that person's assistance on a difficult case because of the regulations, people have abandoned their privileges completely. And
this is an extremely, and both of these issues are really getting to the same problem. And I recall back in, and I practiced obstetrics back in Texas for 25 years. And we made an agreement amongst ourselves that our individual practices would each take a certain number of Medicaid patients every month into our obstetrics practices, so no one would be unduly burdened by a larger number of patients who reimbursed at a lower rate. And that worked great until you had someone who had a complicating medical condition and they had to be referred to a specialist, and it was virtually impossible to find anyone because of just exactly what you describe, and there's those very low reimbursement rates. So as we sit up here and plan a national program that may very well be based on Medicaid, I just think we're obligated to make the program that's already there work first and demonstrate that it can work before we go extending it to increasingly larger segments of the population. Dr. Novak, do you have an opinion about that?
Yeah, my sense is it's no different than when I do something in orthopedics, which is you're not going to introduce a new procedure until there's some data in a small group that it works. And what's being proposed here is to push through massive legislation in an incredibly short order where there's not been full time for people across the country to look at it and examine the problems and try to get it passed before people realize what happened. And then all of us as patients will live with the unintended consequences of those actions.
So we should have evidence-based policy as well as evidence-based medicine.
I suspect that since as Shona has demonstrated, look, there are good people in healthcare, whether they're physicians, nurses, all through the system, top to bottom, in lots of places, not just the United States. But the system within which you are allowed to provide care is as important to the delivery as the people providing it. And so if we're not willing to put the same level of attention and same level of attention to detail and the level of intellectual rigor into designing the system, it is doomed to fail.
Doomed to fail. Sean, let me just, I know I have no time left, but I just wanted to let you know that my grandfather was an academic OB at Royal Victoria Hospital at McGill, and my dad also did his training at McGill Medical School. He did a fellowship at Mayo Clinic back in the 50s. There was only the one in Rochester, and never went back to Canada.
Never went, no.
So just, and I am so grateful you're here today, and thank you for sharing your story with us.
I don't want to pull down any doctors or anything from either side of the border. It's just what they're able to do.
The doctors and nurses are all good people. The systems that they're having to work under are where we're encountering the stress. But again, thank you for sharing your story with us today.
Thank you, Dr. Burgess. And now I will recognize myself for 5 minutes. And I want to just point out that this legislation is not coming out of nothing, that there are, I'll just mention 3 examples of best practices or good care, medical home, if you want to call them that. Cleveland Clinic is one, Mayo Clinic is another. Johns Hopkins, all have been very participatory, and many of our hearings have been focused on areas where practices have worked and where we see examples in small communities. I want to start with you, Dr. Schern. Mental health and substance abuse are some of the most chronic and disabling of conditions. Treatment often does not begin until as long as 10 years after diagnosis. And diagnosis, we all know, oftentimes happens much after the symptoms begin. This increases the risk of developing a very costly disability. Mental health and substance abuse conditions often also go hand in hand with other costly chronic conditions like diabetes and heart disease. Can you comment, and I want to turn to children as well as a former school nurse. We must address that. But I want you to comment briefly on how we might be able to improve the provisions of the draft bill to better guarantee earlier access to mental health treatment. We tried to take as many steps as we could, but this is a single, with all the stigmas and stuff still around. Please address this for us.
Well, first of all, I'd say that we're lucky to have the Institute of Medicine report on prevention in general, and there are many things we can do universally to drive down the rates of mental illness over a long period of time. So one thing we should think about, and I think that the community task force that's anticipated in the bill is in fact moving in the direction of the evidence about what's effective in terms of prevention. I also think that the inclusion of mental health screenings in adolescents as recommended by the Preventative Services Task Force and as is included in the bill is a very important step forward. You know, it's ironic that we test eyes, we test hearing, we look to see whether or not there's a scoliosis in the spine, but we don't test kids for the things that they are most at risk for routinely, and those are social emotional problems. We have data that indicates that when we do that with an appropriate model, as the Preventive Services Task Force has recommended, we can effectively identify and treat those conditions, and that will be beneficial in the long run. Anything we can do to strengthen those provisions, I think, would be very helpful.
And let me just, then I'm going to have to ask you to submit this to the written record. If you have ideas about how we could better support better integration of behavioral health and medical care, as well as in a way of maybe branching out. Hopefully this will be a beginning start, and then we can expand upon it. You mentioned children, naturally, because when you talk about health care and mental health, really, as you know, Dr. Edelman, Marian Wright Edelman, that's when we should start looking at screenings. I want you to focus on a different topic. When you mention children, I always think of the mother. And I want to elaborate on the importance. I would like to hear you elaborate on the importance of ensuring that women receive adequate maternal care coverage and the effect of a mother's health on the health of her children. It's so clear to those who have studied it, if you have adequate prenatal care, your chances of having a healthy baby are that much more important.
Well, and a depressed mother is going to not be the best mother for her child. And so what is good for the mother is always good for the child. And so it is in all of our self-interest to make sure that mothers do get prenatal care, that any problems that they have or substance abuse problems, domestic violence problems, other things that may lead to them being less able to do all they need to do for their children, that those can be detected early and treated early, because the impact on their children in the short and long term will be enormous. And we also just know the cost effectiveness of prenatal care. If they are having babies that are low birth weight, are not adequately nourished, and don't know how to take care of themselves and their children. So I just can't, you can't separate the two. And so I think going forward, we should make sure that mothers are in good shape and children are in good shape. And I'm happy to submit additional evidence of the effectiveness of prenatal care and the effectiveness of maternal care, and hope that there will be a full-fledged capacity to make sure that all children have mothers who get full maternity care in this bill.
Thank you very much. We've done a bit of work in Congress recently to recognize the situation around maternal mortality, but also the fact that I don't think many Americans realize that this country, United States, has one of the highest rates of infant mortality. 27th out of 30 industrialized countries. That's a red flag for starters, and I want to thank each of you again for your testimony. And now I will recognize Ms. Christensen for 5 minutes for her questions.
Thank you, Madam Chair, and thank all of you for your testimony. Ms. Chin Hansen, AARP has taken a position back a few years ago in support of lifting the Medicaid cap for the territories. This bill,
Could you say that?
AARP has taken a position in support of lifting the cap on Medicaid for the territories. Yes. This bill does not go that far. Is it still the position of AARP that all of the federal programs should be equally accessible to all Americans, regardless of where they live?
As you have in my written testimony, that it does speak to really supporting that elevation. So it is something that we continue to support.
Thank you. Thank you. Dr. Shern, let's see. You talk about providing mental health care and the savings that we would realize from that, and the reduction in the productivity losses that we experience, and you give some pretty good figures to back that up. But I wonder if, just for the record, if you would speak to the impact of treating mental health, mental illness on chronic disease, and how that would also produce savings in terms of chronic disease treatment.
Yeah, Ms. Christian, as I said in my verbal testimony today, mental health conditions are the most likely co-occurring conditions with other chronic illnesses, and when they occur, there is lots and lots of data that indicates that the course of treatment is much rockier, costs are much higher, and outcomes are much poorer. We have a study of older adults with diabetes called the Prospect Study, who also had depression, half of whom were randomly assigned to effective depression treatment. The other half were assigned sort of a watchful waiting counseling, but to balance off the amount of time that was spent. What we found was, over a 2-year period, those people who didn't have their depression effectively treated died at twice the rate of the individuals who had their depression effectively treated. And in this study, we found that in the first year there was an overall cost increase for care, but in year 2, the overall cost of care for those people declined and their clinical status improved. So we have lots of examples of what's called collaborative care models in which the entire person's needs are addressed. In this case, we're talking about diabetes and depression. Additionally, and quickly, if you look at workplace presenteeism and productivity, there is also ample data, and this gets to your earlier point, I think, about thinking about costs more broadly than simply the costs within healthcare sectors. Mm-hmm. There's ample data that shows that these are very cost-effective programs that have effective return on investment.
Thank you. And Mr. Edelman, I think most of the questions that I wanted to ask you have already been asked, but you know that I've always shared your passion and your commitment to making sure that every child and pregnant female has been covered. We're expecting a PAYGO bill to come to the Congress shortly. I think it's still coming. And cost being the major barrier to achieving what we all know we need to achieve on behalf of children and really all Americans. Do you agree that it's important to enough to take this issue out of PAYGO if that's where it needs to be?
Well, I don't think we have a money problem in the richest nation on earth. I think we have a values and priorities problems, and if we can find the money for all the more powerful special interests, if we can continue without having had a PAYGO for the tax cuts, many of which came through the Bush administration, if we could find the money so quickly for bailout the banks and others, if we can continue to have these disparate things, I don't for a moment believe we can't afford to take care of our children. It's really about values, and if we're serious about cost containment, if we're serious about prevention, and if we're serious about creating a level playing field for everybody, and if we believe, as we profess to believe, and which is America's promise, that every child's life is of equal value, then we will find the money to do what is right and cost effective, and so I hope we will do it.
Dr. Novak, do you agree? I don't agree with some parts of your testimony, but I agree with your position on MedPAC, if I understand it correctly, and where you say that using cost control as a driving force behind health reform will turn every American from being a patient into an expense. Do you also agree that this ought to be done regardless of cost because we cannot, as the President says, afford not to do it?
No, I disagree. I think when we look at overall government spending, government should work the same as families. And that at some point we have we actually have a healthcare bubble. It's like we had a housing bubble. Our overall unfunded liabilities are massive in healthcare. And that bill will come due someday, no matter where people want to stick it on the ledger. And so given all the bailouts, and I share the concerns with the other members of the panel about some of the bailouts that have gone on, since they seem to go with whoever has the biggest megaphone. But that is not an excuse to not use basic fiscal responsibility when we're trying to reform health care.
But families do in emergencies borrow to meet those emergencies and make sure that they're taken care of.
Now recognize Mr. Green for 5 minutes.
Thank you, Madam Chairman. Dr. Stern, I'm a co-sponsor of H.R. 1708, the Ending Medicare Disability Waiting Period Act, and it would actually phase out the 24-month disability waiting period for disabled individuals. And I want to thank you for being a member of the coalition to end the 2-year waiting period, which has more than 120 members. Can you speak on the importance of that elimination of that 24-month waiting period for individuals with mental disabilities and illnesses, even with the creation of this exchange that's in the bill?
I think it's very important that we eliminate that waiting period. It's such a counterintuitive thing. You know how difficult it is for someone to qualify for SSDI, to make it through the disability process. And people with mental health and substance use conditions have a particularly difficult time making it through. And then once one finally gets through, to say, well, in 2 years, we've now agreed that you have a chronic illness that needs to be treated, and say, well, the good news is you made it through the SSDI. The bad news is we're not going to be able to provide you health care coverage for 2 years. It makes no sense. So I think that repeal is really important. Anything we could also do to expedite the elimination of the discriminatory 50% copay in Medicare. We took care of eliminating it over a 5-year period. We have good data to show that in fact drives costs on the inpatient side by denying people or making it more expensive for them to get ambulatory care. So we're very enthusiastic about reducing that 2-year waiting period, and anything we can do to drive down that copay would also, I think, be very cost-effective and beneficial.
Dr. Edelman, in Texas we have the largest uninsured in the United States, and approximately 900,000 children uninsured. Approximately 600,000 of those children are Medicaid eligible but unenrolled, and the remainder are S-CHIP eligible but unenrolled. This can be attributed to times in the past when Texas was facing budget issues and required parents to re-enroll their children in S-CHIP every 6 months, and the same with 6-month re-enrollment for Medicaid. There are 2 pieces of legislation. In fact, my colleague, Ms. Castro from Florida, and I both are co-sponsors of it. In your testimony, you mentioned 12-month continuous eligibility for Medicaid as part of the solution to the problem with the number of uninsured children in the U.S. can you explain why that is important? Also, the 12-month for the S-CHIP program.
Well, I think that, you want to keep children enrolled. You should make the enrollment and re-enrollment procedures as easy as you can possibly make it, rather than as difficult as many states, including Texas, has made it. And, we lost a child last year, Devontae Johnson, whose mother tried to do everything right but couldn't get her paperwork sorted out in Texas, and this 14-year-old child died from kidney cancer, which could have been allayed had he not been dropped from coverage for 4 months. And I've been so pleased that the business community in Texas has come now and really understood the importance of investing preventively, and that Texas is losing millions of dollars, in fact, almost $1 billion, by turning down the federal match, and the local taxpayers are paying for it in emergency care. And so I just hope that we can, and we've submitted as part of our longer testimony, all the simplification things, including the 12-month eligibility, presumptive eligibility, express lane, and a number of things that can make it easy to get children in for preventive care. And I would love, Mr. Green, and thank you for your comments this morning, to submit for the record the new study done by the Baker Institute that talks about the cost effectiveness of investing in coverage for all children in Texas and nationally. And lastly, some of the studies that the business community had done in Texas in support of their reforms for 300% eligibility in Texas, as well as for the 12-month continuous eligibility.
Well, and we know that the numbers, you can actually decide if you want to keep children from off a CHIP or even Medicaid. If you make those parents go down and stand in line every 6 months as compared to the year. Now, during that year, they can still be investigated. If somebody finds out that family may not be qualified for Medicaid or even S-CHIP, they can go get that. I appreciate also Congressman Doggett's working with the Ways and Means Committee on the same issue for both S-CHIP and Medicaid. Hopefully we can at least get S-CHIP. It's much smaller, but we need to do that, look at the total goal for Medicaid also. Dr. Novak, let me just ask some questions about your statements. Healthcare reform must be built on foundation consisting of the protection of the right of individuals to control their own health and health care, not special interest of government bureaucrats. I would submit right now, I don't know if it's controlled by government, but it is controlled by somebody in special interest. If you're lucky enough to have insurance and you get pre-approval, I can tell you that it's already going to be controlled by someone that's, whether it's insurance companies or Medicaid officials or someone else. So I agree with you. I want health care to be controlled by individuals, but we all have to answer to someone. And I just can't go to the doctor and get everything I want. They tell me that's not part of the policy or not treated for that. Let me go next to your statement on the first preserving a right to be able to spend their own money. And that, let me understand, in Arizona there's a constitutional amendment that the goal is to preserve the right to always be able to spend your own money for lawful health care services.
That will be on the ballot in 2010.
Is there something in Arizona law that prohibits people from spending their own money for their health care?
No, but it is in federal law from the 1997 Balanced Budget Act that effectively prevents Medicare beneficiaries from spending their own money. So if you're the patient on Medicare and you come to me as a Medicare provider, and let me give you, if you bear with me, because it only takes a moment to explain, to do an example. If you've had your hip replaced, for example, 2 or 3 times, and you need it done for the 4th time, which happens, you want to go to somebody who really knows what they're doing. Well, the physician you want to go to, who does a lot of joint replacements, what we're seeing more and more frequently is that those people are no longer doing what we call redo or revision operations. And the reason is why, for a primary or first-time uncomplicated hip replacement, Medicare pays $1,400.
Okay. I understand where you're coming from. Let me give you another example, though, because I'm out.
Gentlemen, excuse me. You're over almost a minute and a half, so I'd like to end this if I could.
Let me ask you, just compare to that. If someone comes into you with private insurance right now.
You can't ask an additional question.
We don't have time?
If he wants to respond, fine, but we've got.
I just wanted to make the comparison, Mr. Chairman.
About $250 difference for what could be 3 times the work. So if you say, I want Dr. Jones to do the operation, I'll pay you the difference out of pocket because it's that extra time. The only recourse the physician has is to resign from Medicare and not see any Medicare patients for 2 full years.
Well, if you want to respond to that, you can, but I've got to move on.
Actually, an effective prohibition on spending your own money on health care.
If you want to respond to that, we've got to keep.
And a number of members here who voted for that Balanced Budget Act in '97. There's a lot of things that happened since then I disagree with. But I also know one of the concerns is that in an area that I have that's not a wealthy area, if we didn't have that, if we didn't have the current provision in there in the '97 Act, we would not have people being able to find a doctor to be treated under Medicare because they couldn't afford that extra money plus what they're already spending on Medicare. Thank you, Mr. Chairman.
Thank you. Gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman, and thank you all for taking your time to be here. Ms. Holmes, I wanted to talk with you for a few minutes. It sounds like you had an incredible journey.
I did.
And you were happy to be able and grateful and fortunate to be able to find health care. Right. You were here during the first panel, and you've heard what I've had to say about TennCare in the state of Tennessee and our concerns there, because what you outline in your testimony is what I see happening many times in our state. You had to fly 2,000 miles to access health care. In rural West Tennessee, because of all the cost shifting that has taken place, because people are not able to access health care and many providers are no longer taking TennCare, then they find that that health care is available a long way away from them. And sometimes, 30 miles might as well be 3,000 miles if no one has the ability to take you there. And I am just assuming from what I read in your testimony and listening to you that your outcome, had you had to depend on a single payer system that allows you no recourse, that allows you no alternatives, which says take a number, get in the queue, and wait your turn, that your outcome would have been very, very different.
Very, very different. And this is the whole reason why I'm here, because I feel very, to stick my nose in American business. But I was fortunate to be able to come here. But not only did I have to just travel away from my home, I had to travel outside my country. And when it gets like that, because it's actually illegal for me to try and do what I did in Canada. And that's what we have to be able to open the doors of communication about and realize that you get ration care. It's one thing to not have insurance, and it's another thing to have insurance and not have doctors.
So basically, your government provided insurance. When you needed it, your government provided insurance was worthless to you.
Exactly.
So you mortgaged your home, put a second mortgage on your home. Your husband picked up a second job, and you got the money that was necessary, the $100,000, yes, to pay for that. Now, when you had flown to Mayo and then you went back to Canada with your test results, and you said, all right, here it is. I'm going to be blind in 6 weeks. Did a bureaucrat make the decision or a physician make a decision?
They wouldn't even look at my medical reports. It was get back in line and wait till we get you.
So the bureaucrat turned to a citizen and said, you're out of luck. Get in line.
Get in line.
That's real compassion, isn't it?
No, absolutely zero compassion from a country that's known to be compassionate. The same country that will cover illegal immigrants the second they arrive in our country.
Okay, thank you, ma'am. Ms. Hanson, a quick question for you, and thank you for being here, and I know you all work hard for our nation's seniors. I have lots of seniors in my district, and I had the opportunity this weekend to visit with some of them. They are really very concerned about what they've been hearing from the Obama plan because they feel like they've had money taken out of their paycheck every week, and now they get to near retirement or they get to retirement, and they're being told basically that that is worthless to them, that if there is a nationalized plan, that they're going to be treated more like they're feeling they're going to be treated more like Medicaid than Medicare. and they are very, very concerned about losing Medicare Advantage. They're very concerned about losing options. They're concerned about losing their Part D coverage. What would you suggest that I tell these seniors that say, I have been putting money in? It is my money. It has come out of my paycheck. I have been letting the government have first right of refusal on that money all of these years, and now it is basically everybody's going to have the same thing. So how do you respond to that? What should I tell the seniors?
Well, I think that what I've heard that the president said that if you have current insurance and it works for you, you can keep it. So I don't know if in this discussion whether it is that everything comes back into the pot. And I don't think that the Medicare program is meant to be structurally dismantled. So I think that my sense is that their assurance, whether it's the Medicaid program that Dr. Edelman has spoken about and Medicare, I mean, we have these right now codified in law with each of these different parts. So there is that. I think one of the things that we want to do is to make sure they get best value for their hard-earned money for what they've spent. So in other words, we want to make sure they get safe care. We want to get timely care. We want to make sure that when they need medications, and most older people have medications, the fact that it's affordable for them. So these are the things that I know ARP really strongly supports. And so I think the ability to really square as to what is discussed about President Obama's plan and the principles of maintaining choice, coverage, and private options.
Thank you. I yield back.
Thank you. Gentlewoman from Ohio, Ms. Sutton.
Thank you very much, Mr. Chairman. 5 minutes isn't going to do it, but I'm just going to request that Ms. Wright-Edelman and Ms. Chen Hansen and Dr. Schern, if I can follow up with you outside the committee to talk about some ideas of how we might strengthen some things and make this work for our children and our seniors and those who have need, Dr. Schern, that you have so eloquently identified. And I want to thank you very much, Ms. Robertson-Holmes, for coming and testifying, and Dr. Novak. And I want to just address the issue that I think that you raised. And I think it is very important as we have this discussion to talk about the reality that this isn't just about getting people health care insurance. This is about improving the delivery of health care to people when they need it the most in a way that makes sense both for health outcomes and economically. And so your point is well taken when you talk about you paid for your insurance, right? And then when you needed it, it wasn't there. Okay. Now, I guess I listened to you and I'm so struck because I was in the state legislature in Ohio and I did a lot of work on this issue related to the private insurance industry and that very same problem, people who paid for care. And then when they needed it, and their doctor said they needed it, they weren't, the insurer wouldn't pay for the coverage that they had been paying for all of this time. And there was a person by the name of Linda Kearns. Linda was it's K-E-R-N-S, doctor. And Linda was a witness who came in to testify. And Linda was a very special person, as most people are, but she was special because she was actually an HR person for an insurance company, okay? And Linda had a history in her family of breast cancer, that it was a very aggressive form of breast cancer. And so her doctor, when she went in for treatment that she was vulnerable to this potential for breast cancer, the doctor wanted to treat her aggressively. And the insurance company bureaucrats overruled the doctor and said, no, I'm sorry, you've been paying for coverage, but that coverage, that care is not going to be provided. We don't think you need it. Okay, so she didn't get it. She didn't get that coverage. Now, what she did was what you did. She eventually, over time, with great delay, raised the money and went into debt to get that surgery. But there was a delay, right? And so there's we really never know the value of that delay to the health outcome.
Irreversible tissue damage, no question.
Right. And in this country, unfortunately, there was no recourse for her, even if there was a proven health consequence to the unreasonable delay or denial of that coverage. Even though if a doctor had done it, if a doctor had said, we're not giving that to you, and then he was found to have unreasonably delayed or denied, then there would have been a malpractice case against them. There was no accountability for that private insurer to be held accountable for the health outcome other than the cost of the procedure, not the loss of life or health.
Exact same situation as we have, and there's no accountability from the government.
Okay, and see, this is my point, though, isn't it? Because you experienced that under your system. We see people experience that here under our system as well, and people going into bankruptcy, people going because the costs are spiraling or they don't have access to the care they need when they need it. And the problem is, and I guess maybe what I would just ask is that if you had, and you talked about the need to have some competition for your government-run plan, and that's exactly what we're offering here. We're assuring that people will have access to coverage in this country. And, and right now the private insurers are the only game in town. And so if they unreasonably delay or deny, no accountability. But if we have a public option that also allows people to have the chance to purchase it, that can not only drive down costs, but I would argue can drive up the quality of the delivery of care. And so I just point that out because I can't help but think of Linda, who.
Ms. Robertson, you've got to turn that mic on because otherwise you won't be transcribed.
The major difference between her and I is that what I did by coming to this country, mortgaging my house, et cetera, was illegal for me to do at home. It's not an avenue for me to do at home. I cannot step out of that. I'm mandated to use that, and that is it.
And you would have preferred to have the option of buying private health insurance, and then you would
either
be resolved.
Or if worse came to worse, the same situation that happened to me here, I could have at least stayed in my house, had my children with me, had my father, months before he passed away, still with me at my hospital bed. Instead, I was in Arizona, 2,000 miles away, alone.
I understand, and I thank you very much for your testimony. And I know that I'm out of time, but so bureaucrats there, bureaucrats here. Of course, this bill, I know you had the question, Dr. Novak, from our chairman emeritus about the exact language that you used in your testimony to describe the bureaucrats that will, in your opinion, be performing the functions under this bill. But it really does provide, the bill, if you find the language, it provides for health care professionals to do the analysis. And of course, what we must tell the American people is that right now, insurance companies are doing it. So with all due respect, thank you.
Right, now listen, I'm sorry. Is the gentlewoman from Florida, Ms. Castor, and I apologize that I passed over you by mistake.
Thank you, Mr. Chairman, very much, and thank you to all the witnesses that are here. And to Dr. Shern, you were an outstanding director of the Florida Mental Health Institute in Tampa at the University of South Florida. They miss you there. We miss you. USF is doing great things, as you know, in medical, in healthcare policy and research. And, you know, back in Tampa, before I was elected to Congress, I served as a county commissioner. And the county government there had the responsibility for all health and social services, including fairly robust children's services compared to many other places across the country. But I was always floored by the total lack of mental health care services. There is nothing. There is nothing for these families that struggle day to day with what's going on in their homes. Now, of course, the county government also had responsibility for law enforcement and the county jail. And the greatest advocate for mental health care services was always the sheriff and the folks that were running the county jail, because they understood the population in jail. And that's the most expensive way to address mental health care in America. So I'm pleased that the discussion draft here in the House takes the first few steps in providing that comprehensive, early integrated care. And there's no better place to start, of course, than with children. You know, I think as a mother, what would I do if I didn't have the same pediatrician that I've had for my daughter's 12 years of life? To be able to just make that phone call, to call a nurse in the office, is very cost effective rather than trying to chase down and go to a clinic or go into the emergency room. We're all paying for that very expensive model out there. If you have health insurance and you think you're not paying for other people's care right now, you're wrong. You are that's one of the reasons your health insurance bills and co-pays have been increasing over time to such a great extent because of the uninsured showing up in the ER. But to promote this early integrated comprehensive care reform that we've taken a stab at here early in our discussion draft, I'd like you to focus on a couple of things. Workforce. We know we don't have those primary care medical professionals, and I'm not sure we have the mental health professionals that we need. Are we doing enough in our discussion draft to tackle that problem? We've also, and I'd also like you to address the terrible bureaucratic red tape. Ms. Edelman has emphasized that time and time again. You have some good recommendations in here, but I don't think the discussion draft goes far enough. We need, you know, in the state of Florida, we have 800,000 children that do not have that easy access to the doctor's office. The state of Florida at one time even quit printing the application form for SCHIP. So what else can we be doing to knock down these crazy bureaucratic barriers that make it difficult for a parent just to walk into the doctor's office and make sure that their son or daughter gets a checkup? So the workforce issue and this terrible bureaucracy. Go ahead.
Well, workforce is a critically important component, and I'm heartened that it's addressed in the bill, and of course we'd always like to be able to do more because we have a real pipeline problem in terms of people who are being trained to deliver the services that we need across the spectrum. And you talked about primary care physicians, and I think we continue to rely more and more and more on primary care physicians in the medical home, and as we know, our current incentive system isn't producing enough primary care physicians, and we're not reinforcing them or rewarding them to the degree to which we can or should. Additionally, I think we need to think about what we can do to continue to improve practice of people who are in practice now. We don't have very good models for doing that. We have kind of what's been characterized as the Nike model. We sort of train them, and they say, okay, go out and just do it. We give them CME, but we know that the CME doesn't do what it needs to do in terms of improving skills. And there are other models, and some of the hope of HIT is better support, and comparative effectiveness research is better support for people to make better decisions. And I think I will defer to my colleague, Ms. Wright-Edelman, to talk about bureaucracy.
Well, I just think a single eligibility standard for everybody, for all children, that's why we suggest 30%, will make it easier rather than having all of these different eligibility standards for children. Right. A single set of benefits that are child appropriate is going to make it a whole lot easier. And secondly, and third, we talk about all the simplifications, and we have it in legislative language. They're all included, and the All Healthy Children's Act would be another terrific start. But getting rid of all this state lottery and all the disparate things and the two child health bureaucracies, whether the children are in exchange or in EPS, in Medicaid or in CHIP, they should all get what they need with a single eligibility standard, comprehensive benefits, and with a simple set of measures that we all know how to do. And I just hope that you will look at the specific legislative language. We'll be happy to submit as part of our testimony. And these are the true child health reforms we need in order to make sure that all of our children get what they need.
Mr. Sarbanes.
Thank you, Mr. Chairman. I want to thank the panel. Mr. Chairman, I want to thank you and Chairman Waxman and everyone who's been working on this issue for so long, because this is it. This is not a dress rehearsal. these panels that we're having probably are kicking themselves that they are here to speak on an actual discussion draft that includes these critical proposed changes to our healthcare system. And I just hope that Americans watching this realize that this is exactly what they were pushing for in the last couple elections, where they were expressing their frustration with the current healthcare system. This is our chance to get this right. It doesn't have to be perfect, but we have to get a new framework in place, one that we can build on, and one that answers the frustrations and the feeling of helplessness that millions of Americans feel out there. I think the source of that is manyfold, but I'll point to a couple things, that sense of helplessness that I'm describing. One is that you deal with an insurance industry that appears to be primarily engaged in the exercise of denying payment for the kinds of services that people need. And there's a paper chase. You get these things in the mail that say, we will not pay, this is not a bill, this is their third notice, this is your fourth notice. Many Americans just give up after a certain point because they can't fight it. So that's one source of the frustration. That's why I think we need a public plan option to compete. And I'm not going to revisit that discussion, but as the train leaves the station on healthcare, if public plan isn't on the train, it's a train to nowhere. It's got to be there. The second source of frustration on the part of many people is they know that there are certain kinds of things that if that was reimbursed in the system, it would be better for their health. It would save the system money over the long term. They can see it. It's right there, but the system doesn't cover it. Elderly patients know that if they can spend another 20 minutes with their physician or half an hour, God forbid, that in that time, the physician could better understand their situation and probably prescribe a regimen that would make a lot more sense for that patient and save the system over the long term. But physicians who do that are penalized by a system that doesn't recognize that kind of primary and preventive care. So that's another thing that needs to be on the train as it leaves the station, primary and preventive care. And the other one is investing in the workforce, because if we have the coverage, that's all very well. If you show up with your insurance card, but there's no providers to deliver the care. So these are all things that are part of this draft. This is why people need to be incredibly excited that we are talking about this right now. This is it. Yes. This is it. This is the moment. Now, with that preface, let me go to healthcare delivery, and I wanted to ask you, Ms. Wright-Edelman, because you've talked a lot about S-CHIP and getting these services to children, but we continue to be frustrated on kind of the delivery system. Congresswoman Capps and I have pushed to try to create more school-based health centers and also allow for reimbursement of services provided there if they would otherwise be reimbursed if delivered in a physician setting, a physician office setting, and so forth. Could you just speak briefly to this idea of capturing people where they are, this concept of place-based healthcare? Go to where the children are, make it easier to access services at that point on the front end. 98% of our kids, ages 5 to 16, are in one place 5 days a week for 6 or 7 hours. We ought to take advantage of that. So if you could speak to that as part of this overall perspective.
I just want to say amen. You go to where they are, you make it as easy as you can. We need to expand community health centers. We need to expand school-based health centers. We need to, again, if mother's in WIC and that's where kids are coming in, you get them enrolled and you make sure that you're making it available. And one of these days I look, as we talk about health and school reform, is that we can really make the new schools that we construct real community centers. And Cola co-locate services so that it's easy rather than hard for people to get their care. So whatever we can do to go where children and families are and to make sure that it's accessible would be terrific. I think none of this is rocket science. I think we know how to do it. And I just want to reemphasize what you have just said. This is it. You've got all the skeletons for what you need to get done in your plan. We just need to kind of finish it, make sure that you've got these structural reforms there. And I would just like to end one little thing, because this is not a dress rehearsal. This is a window of opportunity. If we miss this opportunity, we're going to lose more generations of children and see escalating costs. And I just was looking for a thing that's in the written testimony about the president's statement, and I think it states what you have stated in strong terms. But he says, I refuse to accept, when he was signing the CHIP bill, that millions of our kids fail to reach their potential because we fail to meet their basic needs. In a decent society, there are certain obligations that are not subject to trade-offs or negotiations. Health care for our children is one of those obligations. This is the moment to fulfill that obligation. For you to fulfill it, you know how to do it. You've got lots to build on. We've been working, and many of the leaders here, on Medicaid for 42 years. We know from the incremental problems how to make it simple, but we can address the health infrastructure. You made such a good start. I just hope you can just finish it and make it complete and make sure that this is transformational and true health reform for all of us.
Thank you very much. Yield back.
Thank you. And I think we're done with the questions, but I want to thank all of you again. Obviously, what we're doing is crucial, and we really do plan to move ahead and meet the president's deadline. So thank you very much.
Thank you.
Again, you'll get written questions, within the next 10 days, and we'd ask you to respond to those. And could I ask the next panel to come forward, please?